Hey, this is my second scenario discussion. First one will be linked in the comments down below if you missed it, I think, if I remember to do that. The concept here is that I hate it when social media asks a good question, shows a good x-ray and such, but I don't get any answer except wild-ass guesses in the comments. So in this video, I'm going to give you a case. You can pause it if you want to think about it, and I'll answer it right away. Your job will be to consider the most likely diagnosis, other potential diagnoses, and your treatment plan. After I lay out the scenario, I'll go over the answer. No need to wait or be disappointed about never getting an answer. Here we go. You're called at 2:15 a.m. to a private residence for abdominal pain. It's probably a delta because dispatch flat out asks if the patient's breathing is completely normal, and callers always reply in the negative to that. Even if it's just crying or wincing or anything else, delta. So delta abdominal pain. Just deal with it. You find a 52-year-old female sitting forward on the couch, knees pulled up, clutching her right upper abdomen. She looks mildly diaphoretic, restless, and reports pain that started about 3 or 4 hours after dinner. You were joking around, asking if dinner was any good, and find out it was fried chicken, mashed potatoes, and gravy. No one else is ill. So for your primary survey, the airway's patent, breathing is mildly rapid at 22 a minute, her pulse ox is set 97% on room air. She's got a heart rate of 108, blood pressure of 142/88. Her skin is clammy but perfused. As for disability, she's got a GCS of 15. She's oriented ×4. Looking at her, there's no jaundice. She's got mild right upper quadrant tenderness when she adjusts her position. For sample and history and OPQRST, whatnot, onset is gradual, worsening since about 10 p.m. Provocation, it's worse when she tries to take a deep breath or lays flat, better when she's sitting forward. The quality is sharp and crampy, feels like someone is squeezing her insides. Radiation to her right shoulder blade on the backside. Severity is 8 out of 10. Timing is steadily worsening over the last 4 hours. She's got no allergies. She takes hydrochlorothiazide for hypertension. Her past medical history, her doctor once told her she had gallstones, but she didn't want surgery. Also has high blood pressure, no diabetes. Last intake was a fried chicken dinner. For the event, she tried Tylenol, no relief. So for example, her right upper quadrant is tender to palpation. There's no rebound. She's got mild voluntary guarding. Murphy sign is questionable. You press her right costal margin and ask her to take a deep breath. As she does, the breathing hitches. She stops the inspiration as she gasps. No distension, no lower quadrant pain, no flank pain. Her vitals are stable, but she's a little bit tachycardic. So let's pause it now. Let's talk about this. But first, I want to give you an opportunity to think about it. You have the patient case. Let's think through it. What is your primary diagnosis? What are some other diagnoses? How do you direct your questioning and exam to rule those in or rule those out? And what's your treatment plan? We'll come back in 3, 2, 1. Okay. What's your level of concern? High, moderate, or low in this patient? Moderate. Moderate illness to me is a definitive illness, but not obviously experiencing a life threat right now. Remember, it can change suddenly, so don't be afraid to reevaluate this question from time to time. Let's talk about some differential diagnoses. Number 1 is acute cholecystitis. It fits because she's female in her 40s or 50s. She's had a fatty meal, right upper quadrant pain radiating to the right scapula. The pain is lasting greater than 6 hours, not just colicky. She's got mild tachycardia, tenderness, possible positive Murphy sign. What you want to ask or test is fever, which would support infection, nausea or vomiting. That can be kind of common associated with that. History of similar attacks after fatty meals. In the hospital, they'll use ultrasound to confirm wall thickening and fluid around the organ. Number 2, biliary colic. Symptomatic cholelithiasis, lith meaning stone, why it could fit. Same risk factors, same right upper quadrant pain radiating to shoulder blade. It's often after a fatty meal. It's less likely because biliary colic is typically transient, less than 6 hours, without systemic symptoms. Resolve spontaneously as the stone moves along. Her persistent escalating pain and systemic response, like diaphoresis and tachycardia, lean me towards cholecystitis rather than cholelithiasis. The rule in and rule out is the timeline and the persistence of pain being key. Number 3, in that right upper quadrant is acute pancreatitis. It could fit because epigastric or right upper quadrant pain can radiate to the back. Nausea is common. Risk factors or gallstones can be a major cause of pancreatitis. It blocks the pancreatic duct. It's less likely because the pain is usually a little bit more epigastric and boring through to the back rather than the shoulder. Vitals can be more unstable early. To rule this in or rule this out, you want to ask about alcohol history, prior pancreatitis, vomiting. In the hospital, they'll check serum lipase and amylase to help confirm that. Number 4, peptic ulcer disease or peptic ulcer perforation. It could fit due to kind of epigastric pain, sometimes post-meal. It can radiate. It's less likely because the pain is typically not specifically right upper quadrant and not classically triggered by a fatty meal specifically. There's no peritoneal signs yet. Rule it in or rule it out by asking about NSAID use, dark stools, hematemesis, signs of GI bleeding, stuff like that. For number 5, I'd put in acute coronary syndrome. I would always kind of include this, especially in a female. That kind of upper abdominal complaint in a female can be due to inferior MIs and such. It could fit this because there's diaphoresis, nausea, there's epigastric or right upper quadrant discomfort, radiation to the back or shoulder. It's a classic mimic. It's less likely because your pain has GI triggers and localizes more to the abdominal than chest area, but the MI should never be excluded pre-hospitally, especially in females. So you're going to obtain a 12 lead, ask about cardiac risk factors, dig into chest pain and shortness of breath. Consider right lower lobe pneumonia or pleurisy. Some lung stuff can radiate or involve the right upper quadrant. It could fit because the pain is worse with deep inspiration. There may be fever or chills. We haven't really looked into that a whole lot. It's less likely because the pain location is more abdominal than chest. It's not really as thoracic. There's no cough or respiratory distress. We're going to ask about specifically about the cough and sputum and fever. We're going to auscultate lung sounds for crackles or diminishment. So in this case, the real diagnosis is acute cholecystitis. Pathophysiology associated with this is that a gallstone lodges in the cystic duct, blocking bile flow. The bile stasis leads to irritation and inflammation of the gallbladder wall, and over hours, bacteria can infect the stagnant bile. It's commonly E. coli, but Klebsiella can be involved as well. The inflamed gallbladder presses against surrounding structures, causing localized right upper quadrant pain, Murphy's sign, referred pain to the right scapula via the phrenic nerve. If untreated, it can progress to gangrene, perforation, or sepsis. Pre-hospital treatment priorities are airway, breathing, circulation. Duh. We always kind of do that. She's maintaining her airway, her SATs are good, it was 97% on room air, and her vitals are stable aside from mild tachycardia that I would associate with pain. I'd monitor her closely. Systemic infection or sepsis could develop. Number 2, IV access and monitoring. Establish a large bore IV, like at least an 18 gauge. Place her on a cardiac monitor and obtain a 12 lead EKG to rule out the ACS stuff. Capnography, if available, that's always fine. Number 3 is pain management. Opioid analgesia like fentanyl is appropriate. Fentanyl is preferred in many systems because it has less risk of sphincter of OD spasm, although this risk is more theoretical than clinically significant. Morphine's still safe. It provides effective relief. Adequate pain control improves respiratory effort and patient cooperation. Number 4 is antiemetics. Nausea and vomiting are common associated with this. So ondansetron, like 4 milligrams IV or IM, help make the patient a lot more comfortable. Gentle IV fluid hydration with normal saline would be the last part with saline or lactated ringers. It'd help with the tachycardia and potential volume depletion from poor PO intake. I would avoid aggressive fluid loading unless hypotension develops. Finally, consider infection. At least think about that. Antibiotics are not usually given pre-hospital unless you're in a critical care type of flight program with protocols for that. But it's important to recognize the potential for sepsis. Fever, tachycardia, hypotension, altered mentation may indicate progression. I would transport to a facility capable of surgical intervention. Just general surgery can probably do this. I think removing gallbladders is right up there with the appendix, is one of the first surgeries that surgeons learn. I don't actually know what the most common first surgery is. But gallbladders are right up there. Lap chole is a fairly common thing. We want to avoid prolonged scene time. This isn't a fix it in the field condition, but I'm also not in a massive rush either. For ongoing assessment, you're going to reassess the vitals frequently. Watch out for hypotension, worsening tachycardia, respiratory distress, stuff like that. What not to do, first of all, this is mostly mental. Don't dismiss symptoms as just GI. You got to rule this out in MI with a 12 lead. You can't give them food or drink. The patient will likely need NPO status before imaging or surgery. Don't assume biliary colic versus cholecystitis based on the history alone. That distinction is made in hospital with ultrasound and labs and serial exams. Explaining my rationale associated with this, the pain and nausea control improve the patient comfort and reduce symptomatic stress responses. Fluids and monitoring address the risk of sepsis and hemodynamic instability. EKG screening rules out ACS, which is a dangerous mimic. Timely transport ensues surgical evaluation before complications like gallbladder necrosis or perforation. In short, IV, monitor, EKG, analgesia, antiemetics, fluids, and transport to a surgical capable ED. So let me know if you like this kind of video by liking, sharing, or giving me a quick sub. None of those cost anything. If it seems to be well received, I'll continue with regular case scenarios. I'm Angry Bill. This is Pre-Hospital Wisdom. Until next time, stay safe.